Hello, and welcome to Insight. This is our monthly care partner training. We are with the Frontal Degeneration Association, and we're going to be talking about FTD this month. And I would like to introduce you to Esther Kane. She's the Association of Frontotemporal of Dementia. She joined as the Director of Support and Education in November of 2020. Previously, she served as the Director of Wellness at CareOne Management, a company that provided elder care services throughout the Northeast United States. She brings clinical, educational, managerial, and marketing skills along with a passion for quality care for those who are living with neurological conditions. Her work reflects a strong commitment to the importance of education and training throughout the spectrum of diagnosis and delivery of quality care. In her role, Esther will ensure that AFTD support services and education program advance early diagnosis and improve access to quality care and effective support, as well as to ensure that clinical information provided to healthcare professionals in the AFTD community are current and accurate. Insight, we provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment, their partners, and the community. And our vision, a community of those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. I'm going to go ahead and stop sharing my screen and welcome Esther, and thank you for presenting to us. We do have some people in the room and people online. Feel free, if you're online, to put any questions during the presentation in the chat. If you're in the room, I'm going to leave the mic on so you guys can just ask, as long as Esther's okay with that. So there we go.
Wonderful. Well, thank you, Melissa, and thank you to Insight Memory Care for having us here today to be able to talk a little bit more about FTD and what it means to kind of live with an FTD diagnosis. And so, as Melissa said, my name is Esther Kane. I'm AFTD's Director of Support and Education. And I am excited to talk to you more about FTD and to learn more with you. So I do hope this can be interactive. Please feel free to reach out in the chat or let Melissa know if you have questions as we go along. Hopefully we can have a little bit of a discussion as we learn more about FTD in this process. So let me get my screen up here and hopefully this works on the first try. So Melissa, I'm going to assume this is working well unless you tell me it is not working well.
We are good.
Good. So what is FTD? The title of this presentation is FTD, What, How, or Why? And I think really what we want to talk about today is a better understanding of what is FTD, better understanding of the different subtypes of FTD, the different presentations of an FTD diagnosis, understand some of the supports and services that are available to assist families after an FTD diagnosis, and really educate people on AFTD's mission, values, and resources, and the things we have available to support those on an FTD. I don't really like to use the word journey, but living with FTD is probably the best way to put it. So first, let's take a little bit of a look at dementia, because we can't really talk about FTD if we're not talking about dementia first. I think one of the things that's the hardest with dementia and changes in behavior or memory or language is that we underestimate the power of our brains and what our brains can do. So the human brain is an extremely complex part of the human body, and it really affects every single part of who we are as a person. So changes to our brain affect so many aspects of how we think, feel, touch, smell, how we respond emotionally to other people. And so it's important for us to really just take a moment and just respect what our brain does and how it operates. And then really take a moment to understand that changes in our brain can affect who we are as a person at times and change how we respond in our personality. And we're going to talk more about that as we look at FTD, because in FTD, it's really a disease that affects people's personality. It affects how they respond to other people. And some of the most difficult challenges for families and for those around them is just the loss of the person that once was in relationship and the changing of those roles. So what is dementia? NIA actually, or NIH defines dementia as the loss of cognitive functioning, thinking, remembering, and reasoning and behavioral abilities to such an extent that it interferes with the person's daily life and activities. Very often, though, if you were to ask any person on the street when they think of dementia, what is dementia? They're going to tell you it's something that you get when you're old and that you just get forgetful. And that's what dementia is. And that's not really a fair representation of what dementia is or what dementia, how dementia affects people with the diagnosis. Dementia actually describes a level of impairment and functioning, and it is likelihood dementia does develop with age, but there are child causes of dementia. There's childhood dementia diseases. Some forms of dementia, like FTD or young onset Alzheimer's, actually occur in midlife or can occur at younger ages. We have people with a diagnosis of FTD as young as 30 years old, 24 years old. And so it's important to understand that dementia doesn't just affect the elderly, it can affect at different stages of the life process. And it can affect more than just a person's memory. And if you leave today with that little bit of knowledge, you are going to be more well informed than most of the world right now when it comes to dementia and what dementia looks like. Dementia, what is it's an umbrella term. It actually covers a large swath of different types of cognitive decline. Alzheimer's is by far probably the most common form of dementia, and we're going to talk about that in a little bit. But there's also Huntington's disease, Lewy body dementia, Parkinson's dementia, vascular dementia, so dementia that's caused by stroke or diabetes or other types of vascular changes. And these are just a few examples. There's actually over 100 different kinds of dementia that exist, and they affect different people in different ways. And so when we talk about dementia, we want to talk about it in a broad way and just really recognize that it can affect people in many different ways. Here's a little bit of a look at some of the most common forms of dementia. Alzheimer's disease affects about 5.8 million people in the United States. Memory loss is one of the most common symptoms that you see in Alzheimer's disease, and it's caused by something called amyloid plaques and tangles. And this is important even for those who are providing care to understand, because a lot of the disease-modifying drugs and treatments that are coming out to actually fight these specific proteins or the amyloid plaques and tangles. And so when you have a disease like Lewy body dementia that's actually caused by Lewy body protein deposits on nerve cells, the drugs that are attacking amyloid are not going to be able to be beneficial in somebody who has Lewy body cells on their brain. The same is true in frontotemporal degeneration, where most often we see the proteins tau, TDP43, and FUS, which are causing the atrophy that's leading to the brain disease. Vascular dementia makes up about 10 to 15% of all dementias. And most people, about 40% of all dementias, have a vascular component, which means that you could have FTD and have a vascular component, meaning you could have some neurodegeneration that occurred from vascular reasons within your system. We hear a lot from people that they went after they had a brain autopsy and it said, I had FTD and vascular dementia. What does that mean? And what that means is that 50% of the time, people actually have multiple dementias that are evident within their brain. But what this also tells us is that what families really need is to understand what's happening in the brain and then be able to receive support based on the symptoms and what's occurring. Here, I like to show this slide because these are some different MRI slides, and you can see that in every one of these brains that have different forms of dementia, there's different damage occurring to the brain. So in frontotemporal dementia, you're going to see a lot of damage right here to the frontal lobe of the brain. Right here, this is all atrophy that's occurring in the frontal lobe of the brain. Whereas in Lewy body, you're seeing damage occurring in other parts of the brain, and the same with vascular dementia. And this is important as we talk more about our brain and how our brain works, because this affects how the person kind of demonstrates and what the dementia looks like in the person. I think one of the really important things that I always want to make sure that we're getting across is that
Esther,
Yes, go ahead.
We have a question from your previous slide.
Okay, go ahead.
The blue part is the normal and the yellow is the dementia.
So it's the blue, the normal, and the yellow, the dementia.
No, so what you're seeing here is the black spots. These are the atrophy spots in the brain. So if you look here, you see right here where it's all black.
Yes.
This is where there should be brain mass. Here on the normal brain, you see how there's brain mass there. In this black area, this is where you see the atrophy. Then frontotemporal dementia here, if you look, this would normally have brain mass, and you can actually see the atrophy that's occurring to the brain.
Gotcha.
Thank you.
You're welcome. And Melissa, just so you know, I can't see the questions if they come up, so you're going to have to interrupt me, and please feel free to.
Yeah.
Okay.
Where is she?
So one of the things that does occur, or that we want to make sure that people understand, is that an FTD, the presentation and the symptoms are different than an Alzheimer's disease. And this is really important because how we approach the disease has to be different than we would approach somebody with Alzheimer's disease. There are some things that are universal in the world of dementia when we talk about things like treating the whole person, and there's certain aspects that are going to be continuous. But in general, the presentation looks really different. So very often in FTD, we're dealing with a younger onset dementia. So the person could be 40, 50, 60, 70 years old, usually within that bandwidth, with first symptom onset. Very often they physically are feeling very healthy, but mentally they're having some changes that are occurring in their brain. Very often, some of the most common symptoms we see, and the most common symptom that we see in BV-FTD is something called apathy, which very often gets mistaken as depression. It looks like depression. The person doesn't have a lot of get up and go. We're going to talk more about that in a little bit. But we also see changes in personality, language, and movement. And those are the three domain areas that have the biggest effect that we see within frontotemporal degeneration. FTD has a little bit of a weird history and a weird start, which I think is important to talk about. It was actually discovered first in 1892, so it's been around for quite a while. But here, 125 or 127 years later, we still don't are learning about FTD and how it affects people and their brains. Alzheimer's then described the pathology in 1911, so Dr. Alzheimer, who discovered Alzheimer's disease, also identified PICs bodies in the brain. And then there was a long period of lack of interest. And this is true in the Alzheimer's space too, which is why we are in the situation we are in right now as a country. And it's important to recognize this and to consider this, because we need to have more research and more energy and time spent into better understanding what's happening in the brain so that we can work towards a cure. We say this often, but it's very true. Dementia is not a normal part of aging. Not everyone should be having dementia. This is not something that should be part of what everyone experiences as they age. And therefore, we need to treat it like a disease and look for advancements and cures within the space. And we've learned a lot in the last couple of years. We have gain better understanding of the genes involved in FTD, as well as the proteins that are involved. And we're getting close to having currently, honestly, right now, there are 6 clinical trials happening in the FTD space, which is within the last few years have been some great advancements, and we're moving forward in the right direction. So what is FTD? Frontotemporal degeneration is a cluster of complex disorders. So it actually covers a couple different diagnoses that fall under the FTD diagnosis. And the diseases that fall under this diagnosis all occur here because they all have the same proteins found in the brain. They all have tau, TDP43, or FUS that are located within the brain. And they fall into this FTD or frontotemporal degeneration umbrella. So it's maybe a mini umbrella under the bigger umbrella, if you want to look at it that way. And so we have behavioral variant FTD, which makes up about 50% of all cases of FTD and is one of the more common forms that we see. We then have the primary progressive aphasias, which also make up a large portion of those with FTD. And those diagnoses primarily affect language and language changes. And then we have the atypical Parkinsonisms, or the movement disorders, where we look at corticobasal syndrome, progressive supranacular palsy. And unfortunately, more and more, we are seeing a connection between FTD and ALS. And so there is a growing group of people who are being diagnosed with ALS, FTD, FTD, ALS, FTD motor neuron disease. So they're really battling two diseases at one time. And we'll talk a little bit more about care and support for those with those types of diagnoses in a minute. So here's our little brain here again. And we want to talk about our brain because when we have frontotemporal degeneration, we're actually having atrophy in the frontal lobe of our brain and the temporal lobes of our brain. And you can see them here on the slide. And they control a lot of the behaviors and the language issues that we see, which is why it makes sense that we are now seeing some of the changes as atrophy is occurring in these parts of the brain. So the frontal lobe of the brain actually controls a lot of our reasoning and decision making. It's where we decide where we're going to put our money, or where we're going, how we're going to drive the car, or where we're going, or how we do directions, or how our impulse control. It's where a lot of our emotional and personality is right here on the frontal lobe of our brain, and our safety awareness. So in behavioral variant FTD in particular, that's why we start to see some of the symptoms that we see so actively. The 6 criteria for a diagnosis of behavioral
Esther, we have
variant.
another question.
Go ahead.
So the symptoms on the FTD, do you also see them on the Alzheimer's?
So the symptoms on FTD, do you also see them on Alzheimer's?
Like
Sometimes there is some overlap. So I think some things with like executive dysfunctioning, or the ability to, maybe pay bills may look similar, but they might be caused by different reasons. So versus somebody forgetting to pay the bill, it may have more to do with the inability to plan through a process. So the symptom may look the same, but it may have a very different triggering point, if that makes sense.
Okay.
Esther, there's been a question. Will you be sharing the slides after the presentation?
I can share the slides with you, Melissa, after the presentation.
Okay. And then
Many of this information is found on our website and is available to be able to be read through in various different forms and ways too. So sometimes the slides may not tell as much of a story because I'm talking during the slides versus having the website have it written out for you. So that might be a good resource also.
We're also recording this, so you can always rewatch it. We'll probably have it posted within about a week. So that's the other option.
Wonderful. So when we're looking at the signs and symptoms of behavioral variant FTD, there are 6 symptoms that are part of the diagnostic criteria. So the diagnostic criteria for behavioral variant FTD requires that you have 3 of these 6 symptoms, along with MRI imaging showing atrophy in the frontal temporal lobes of the brain. It's a clinical diagnosis, meaning that we don't have biomarkers yet to give a definitive diagnosis. But based on the clinical presentation, this is the doctor's best estimate as to what's occurring with the person. And so apathy is, like I said earlier, about 50% of all people with FTD present with apathy as their first symptom that occurs. In addition, we have disinhibition, and we're going to talk more about these when we talk about managing symptoms. But disinhibition is the inability to kind of have impulse control and control your behavior. So people who have disinhibition do things like walk up to the lady at the grocery store and say, "You're really fat," and then walk away. And the family is appalled that they just said that. They would never have said that. But they don't have that control anymore to be able to say whether or not something's appropriate or not appropriate. And this can be a very difficult symptom for families and the person diagnosed to live with. In addition, we see deficits in executive functioning skills where there's loss of ability to be able to pay their bills on time, or they don't follow through necessarily with requests or household support, which is why very often the families are some of the first people who notice these symptoms. We also say with behavioral variant FTD, you can most families can track back to changes in employment being the first sign. So their place of work is actually recognizing that they're not doing as well with their management of tasks or projects as they were before, and they're having issues with their employment. And that's usually the first trigger symptom for people that something's happening or something's changing. There's also a loss of empathy, and this is extremely hard for families too, as well as the person diagnosed, because it just seems like they don't care anymore, when in reality it's that their brain has changed in such a way that they're not feeling those emotions the same way, or if they are feeling those emotions, they are not displaying them in the same way, in the way they're talking. So we've had families say things like, I just got married and my mom didn't even care. She didn't care that I got married. The shock, it just didn't make sense. It didn't align. When mom normally would have been overjoyed and the mother of the bride and in every part of the event, and now she just doesn't care anymore. And this is all being caused by the frontotemporal degeneration.
So Esther, we have a question. FTD
Sure.
includes Parkinson's dementia, ? And is aphasia associated with FTD?
So we're going to talk about primary progressive aphasias, and we're going to talk about the Parkinson's symptoms in a little bit. So when we talk about FTD, like I said before, it's a cluster of diagnoses. And so right now we're talking about the behavioral variant version of it. But as we talk more about the primary progressive aphasias, we're going to talk about language. And when we talk about corticobasal syndrome and progressive supranacular palsy, that takes into play some of the atypical Parkinson's type symptoms. Did I answer the question?
Yes, thank you.
You're welcome. So in addition, we see changes in eating habits or diets, and then there's a lot of compulsive ritualistic behavior that is very common in people with BVFTD. Then when we're looking back at our brain, very often primary progressive aphasia results from damage in the temporal lobe of the brain. So the primary progressive aphasias are specifically their language diagnoses. They typically occur because of language changes, and that is what's first seen. But as the disease progresses, very often we can start to see behavior and movement issues that may occur in the disease process. There are three main subtypes of primary progressive aphasia. So it's an umbrella under an umbrella under an umbrella. But we have non-fluent agrammatic, semantic variant, and logopenic variant. And when you're looking at the brain, it makes sense, because if we're going to have changes to the temporal lobe of our brain, we're going to see changes in our speech, our recollection of items or objects, as well as our ability to recall names of objects, our motor function, our speech motor function, because it actually takes quite a few muscles to be able to speak and talk. And so when we're looking at primary progressive aphasia and the temporal lobe of the brain, you can start to see the connection of the language parts of our brain and the disease manifestation of primary progressive aphasia. So the subtypes, when they're split up, non-fluent agrammatic is defined by omitting of words or errors in use of word endings and verb tense and pronouns. So it's also the change in motor speech. So it's a motor change that they have, as well as apraxia of speech, along with the change of the ability to recall names of words. In semantic variant, primary progressive aphasia, this version is a little bit more, and they sometimes call it semantic dementia. It's an inability to recall names of objects. It mimics a little bit more of some dementia symptoms, whereas in non-fluent agrammatic, it really mostly speech is evident in the beginning. And then in logopenic, it's a little bit different. And actually, logopenic primary progressive aphasia is caused by Alzheimer's pathology, but it's a primary progressive form of aphasia. And really what's most important about all of this is that people who are having language issues need different support than people who are having behavioral issues. And we're going to talk more about that in a few slides. And then we have the part of our brain that kind of leads us to the corticobasal syndromes and the progressive supranacular palsy. And so this actually, the damage we see in both of these disorders occurs deeper inside the brain. And the basal ganglia and our brain stem actually control a lot of our movement. All of our cranial nerves are resulted and start in these parts of our brain. So when we have things like the eye palsy that we see in progressive supranacular palsy, you can see the connection to what's happening in the brain and the changes that are happening in the brain with what's being manifested out in the person's body. And so corticobasal syndrome and progressive supranacular palsy are very often misdiagnosed as Parkinson's type diseases. These patients actually don't respond well to Parkinson's medications. And there's usually other symptoms or things occurring that will lead physicians to understand that it's actually a FTD subtype disorder that's actually occurring here. So since the discovery in 2011 of the C9orf72 gene mutation, we have a growing understanding of what's happening in FTD ALS. And I'm going to talk a little bit about the genetics of FTD in a few minutes, but what I really want you to understand here is that there is one gene called C9orf72, which causes both FTD and ALS. And so we are learning more and more that FTD and ALS are connected and they have a strong relationship. And you're going to be seeing more and more rollover back and forth between the FTD and the ALS communities in terms of support and education and understanding of disease management. Before I talk about symptoms too much, do we have any questions about the different subtypes or questions about what's happening in the brain?
That slide with a lot on there and went too fast, one back.
Can you go back 1 or 2 slides? There's a lot of information. That one?
Right there.
Yeah.
Are you, I do have a question. Are you gonna speak, when you talk about the genetic section, which I know is coming, can you also include some information about the sequestosome mutation, which I know is not one of the more common ones?
What was the mutation? I'm sorry.
Sequestosome.
Sequestosome?
Sequestosome.
That also is often causes ALS. It's on the website, so, but it's unusual, uncommon.
Yeah, it's very uncommon,
Yeah.
and it's less aware. What I would recommend is if you want to talk about that more or learn more about that you would reach out to our helpline. We have a genetic counselor on staff who will probably be able to answer your questions specifically about that particular gene. Because today I'm kind of prepared to talk about more of the bigger genes, but I actually am not aware of that gene and the effects of the gene, but the helpline could be a great resource to be able to get the information you're looking for.
Thanks.
No problem.
Yes.
Somebody else has a
So go ahead.
Okay, so she was talking about the primary progressive, aphasia.
Aphasia. Yeah.
So my husband asked me what was aphasia. So did she explain that?
Can you do a simple definition of what aphasia is?
Yeah. So aphasia is the inability to communicate language, is what it is.
Okay.
So when aphasia occurs, the person is having trouble speaking or communicating verbally what they are thinking even. And sometimes it's motor function. Their mouth just isn't working in the way that it needs to work to get the words out. And sometimes it's a word retrieval issue where the mouth and the brain are not communicating the way that they used to. Does that make sense?
Yes.
Okay, here's another question. Can there be a diagnosis of logopenic PPA in early onset AD?
Yes. Yes.
Okay, and then the other question is, will a patient move from their initial variant to developing the other variants over time?
So when people are diagnosed, they are diagnosed with the first presenting symptoms that they have first. So if they first start with behaviors, then they're typically diagnosed, or if they're the most troubling symptoms, with behavioral variant FTD. But very often, as the disease progresses, people experience all of the changes as the disease goes on. So they may start with language issues, but as the disease progresses, most people will start to experience movement and language issues. And I think it's important for people to understand that behavior, language, and movement are all connected in the FTD disorders. So although you may only be presenting with one form of them, as the disease progresses, you may have varying levels of the other symptoms within the disease and may not be as pronounced, whereas it might start with movement issues. It may not be as pronounced when you get to behavior issues as it would have been if you had started with behavioral issues first. But typically people will have all of the symptoms. And we hear very often on the helpline and from families how, you know, does my loved one now have Parkinson's on top of having primary progressive aphasia, or do they have a primary progressive aphasia and behavioral variant FTD? And I would say no, they have FTD. FTD is the broad overarching term. These subtypes just help us better understand what's happening first, and can influence how we want to approach care moving forward. Was that helpful? Did I answer the question?
Yes, won't you?
Does she have a timeline of the progression of
The magic question, is there a timeline?
There's not a timeline, and there's not a timeline because a FTD affects everyone differently. And depending, some people are slow, their progression is long. We talk to families where people have had the disease for 20 years. And some people it's more rapid. What I will say is if the disease is progressing quickly, it usually continues to progress quickly. And if the disease is progressing slowly, it usually continues to progress slowly. But each person with FTD is different, and how the disease affects them can be different. So there's not a real specific timeline. On average, the disease from first symptom onset till people may pass away is usually between 7 and 13 years, but that can vary on either sides of that.
What as a follow-up to that, when you say progressing quickly and progressing slowly, how do you define quickly and slowly?
It would be how quickly new symptoms are occurring, right? So if somebody started to have some behavior changes, but it's just behavior changes, and maybe it's taking a year or two for those behavior changes, and you're not noticing any other symptoms, then that might be a slower progression. If they're starting with behavior changes and within a couple months you're noticing gait changes, they're starting to lose their speech, then as new symptoms are coming in more quickly, that is a more aggressive progression. Whereas if new symptoms are coming in more slowly, then that's a slower progression. Did that answer your question?
Yeah, sort of. I'm just from somebody who maybe has quick progression in two of the categories, but is seeing very little physical deterioration at this point. It's a young onset patient, right? Diagnosed before 60. Started out behavioral and very much PPA, both strong behavioral and PPA at this point, although not the nasty behaviors, luckily, yet. But very little physical deterioration. So I don't know what that disconnect means.
That's common. So that's common. We hear that a lot from families. And what that really is very often people will be physically strong really up until the end. Not everyone has physical changes that occur, but then what they will start to see is like changes in swallowing and eating patterns, which then start to result in some physical changes. But like I said before, every person is different. You don't have to have every symptom to be progressing. But if you're seeing new symptoms or the symptoms worsening quicker, then that is a faster progression.
does age have anything to do?
Does age play into it at all?
Not really. Not that we know of. I should say not that we know of. There's a lot of research going on right now to better understand FTD progression and what we see. But from what we currently know, there's not necessarily really specific indicators that age plays within the role. I will say that if somebody's very young who gets diagnosed, they do tend to have a quicker progression. And there tend to be more concerns as to whether or not there may be a genetic cause or another environmental factor that might have triggered the disease onset.
Okay, and we have another question online. Are you saying there is only genetic indicators, or do we know other factors that contribute to the disease?
So FTD occurs in families 20% of the time is from a genetic factor. 80% of the time, we don't know what's causing it or what the cause is or why it's happening. In some cases, there's a strong familial resemblance, but there isn't a gene identified. But in 20% of the time, there is a known gene that is identified that causes FTD. If it's not genetic, we don't always necessarily know what is causing the disease. Very often, we are looking at environmental or other diseases that might be contributing to it. But there's still a lot that needs to be learned about the causes of FTD.
Okay.
Okay, good. So managing symptoms of FTD. I think what's most important, and if you get nothing else out of this entire conversation, I just want you to know that every person is different. So even when we talk about symptoms, just because your loved one may not have the symptom, or the person who you're caring for may not have the symptom, it does not mean that they're going to have the symptom. It just means that these are common symptoms that we see in FTD. You know, I hear from families all the time that say, you know, my loved one's not aggressive at all, and I'm just waiting for the moment they're going to become aggressive. And, you know, we say to them, they may never be aggressive. Aggression may not be an issue that they deal with. It may not be part of something that happens for them. So you really have to look at your loved one and see what's happening with them, and then treat the symptoms or try to care for the symptoms specifically that you're seeing. I know we all want a crystal ball. We want to be able to look and see exactly what's going to come and what's going to happen so we can prepare. But sometimes in FTD, the best approach is just to handle what we see before us and what we're dealing with right now, because we can't change the future, but we can manage today and help the person do the best that they can today in this very moment. And so when we're looking at FTD, we always want to have a person-centered approach. No two people are the same. We can't assume just because somebody has an FTD diagnosis that they're all going to look the same, because that's not the case. It really depends on how the disease manifests for them. And so we really want to look at the person. We want to promote respect. We want to look at their values. And we want to support independence as much as possible within safety guidelines. And that's always a hard, tricky place to be, and a difficult line to kind of walk on both places.
So we have a question. Do those diagnosed with BV-FTD experience progressive muscle loss without an ALS diagnosis?
In the advanced stages of the disease, they may have muscle loss due to lack of movement, exercise, changes in nutrition patterns. But you really want to talk to your clinician and better understand what's occurring. They may want to do some tests for ALS. If the ALS tests are coming up negative, it may be just a natural form of the disease progression.
Okay.
Does that make sense? No problem. So lack of insight or anosognosia. This is important to talk about because we see this often. It's about 20 to 25% of people with FTD, specifically behavioral variant FTD, have this thing called lack of insight or anosognosia. And what this is that they don't have any real recollection there's anything wrong with them. They feel like they're fine. There's nothing happening. And the family's like, you're not fine. This is not normal. You've changed. And they're not seeing the change. And this can be extremely difficult to get the person to get a diagnosis and to get the care that they need. We have a person on our Persons with FTD we have a Persons with FTD advisory council that we meet with. And she was talking about how anosognosia has affected her. And she was saying how she really didn't think anything was wrong with her. And she was a nurse. And when the doctor showed her testing year over year, she started to say, I see here that something's wrong, but I don't feel like anything's wrong. And so it's important to understand that this is actually part of the disease. It's part of what's occurring in the brain, which is causing this inability to recognize that there's something wrong. And it's not purposeful or the person just trying to be difficult. Very often people will be like, my husband was fine and now he's a narcissist. And usually that's not how these things occur. If somebody's a narcissist, they've always been a narcissist. It doesn't normally just occur in their 50s or 60s when the rest of their life they've had a very different type of relationship. And so, you know, you just want to be mindful of this, that this is a symptom of FTD, and then treat it as a symptom. It's part of the disease. When we're dealing with disinhibition, and I'm going to go through some of these real quickly. Melissa, I don't know if there's specific symptom management people want me to talk about more than others, because I have quite a few slides here and we don't have tons of time.
Okay, we have another question too.
Go
Same
ahead.
question as ALS, but regarding Parkinson's disease.
So you're saying that there's no diagnosis of CBS or progressive supranacular palsy, but the person with FTD is starting to display Parkinson's symptoms?
Yeah.
Yeah. So Parkinson's symptoms can be part of the disease progression in FTD, even if CBS or progressive supranacular palsy is not diagnosed, because with the changes of the brain, we start to see changes in gait and tremors and things like that that can occur. Sometimes Parkinson's symptoms can also be results of long-term medication use in some cases. So you always want to talk to your doctor about that, but not everybody will have Parkinson's-like looking symptoms, but if they do have Parkinson's looking symptoms, it's part of the disease process.
Thank you. So you were asking if people had specific questions on behaviors.
Mm-hmm.
Anyone in this room? Anyone online? Yes.
As a care provider,
Yeah.
so how do we go about coping with if they're saying, oh, you're too fat, or no, I don't do this, or we go to the store, do you constantly keep saying you need to do this, you need to do that? How do we cope with that?
So I think what you have to recognize, and this happens all the time, what you have to recognize is this the disease and it's not the person. So the person has a disease, but the disease is changing their personality and who they are. And it's really hard to separate the disease from the person. And for care partners, specifically spousal caregivers, I think it's a real struggle to see the change in behavior and in the person and then have to separate it out. What we've seen a lot of families do, which has been really effective, is they actually name the disease. So they kind of
name the disease.
They name the disease. It's John that's causing this problem. It's not Ed. So maybe your husband's name is Ed and you've been with Ed for 60 years. And now whenever there's these symptoms that occur, you recognize that it's the disease. It's not Ed. And so as the disease, we're going to say, this is John. This is John doing this. This isn't Ed. And it almost as simple as it sounds, it just helps you separate the disease from the person and recognizing the fact that even though it looks like it's the person, it's not, it's the disease. And many care partners have had great success in being able to make that separation. It doesn't make it easy because when person's personality changes and the roles change in a relationship, it's still very difficult to handle and to manage. I would also recognize the fact that you can't change the person. They have a disease and the disease is outside of their control and they can't change the disease, changing who they are or causing the symptoms or the progression. They have no control over it. And the more that you can recognize that they can't control this, the more that you can understand that you can't try to get the person to change who they are. What we can do is try to change the environment to help the situation or maybe avoid some behaviors that can occur. Did that answer your question?
Yes, but does that mean you're constantly saying, oh, you're thinking all the time for both of you? Are you constantly
Absolutely.
Yeah.
all the time?
Yeah. It's
It
exhausting,
is.
huh? Yeah.
It's exhausting.
Yeah.
It's exhausting. It's exhausting. And I would say that that's why you need support. You need to find other people who are in the same situation that you're in. I know that Memory Care Insights has a support group, as well as there are many support groups that are available on the AFTD website. Connecting with other people who understand what you're going through is the biggest lifeline that care partners can have and people diagnosed can have, because it helps everyone better understand the situation and you feel a little bit less isolated and alone. Because very often as the care partner, you do have to take on a heavier load.
So we have another question from Wendy. I'm starting to see an increased intake of food on a daily basis, which is now also leading to increased bowel incontinence. How do I manage this?
So you have to think that impulse control, disinhibition, and compulsive behaviors are part of FTD. They can't control their management of intake of food. There's a couple things that you want to consider and think about. You want to always talk to your primary care physician because sometimes there's a medical reason that's causing it. There could be many other diseases like new onset diabetes or other things that could change people's eating patterns and what they're doing. But in general, when you're dealing with this, you want to see what can you change in the environment to help this person not overeat as much. So some people have put locks on refrigerators, childproof locks, and they've been successful. Some people have just stopped buying the carbohydrate foods or the foods that they don't want them to eat. Sometimes if you leave out healthier foods, they'll choose the healthier foods because they're easier to access than the snacks. They're choosing the snacks because they're easy access. So not having the snacks, but maybe having, cut up fruit available on the counter, they may choose that over something else that's not as healthy because it's easily accessible and available to them. But you really want to look at your environment and say, what can I change in the environment to help them? Because they're not going to necessarily change their behavior.
Perfect. Can you please talk about how to support independence in doing things for themselves without causing too much frustration?
Yeah, it's hard. It's hard. It's hard to create independence. What you really want to look at as what can they do and is it safe? So looking at the environment, every person is a little bit different. And you have to remember that FTD is different than dementia. So sometimes people living in facilities, the facility wants to group everything with dementia the same, whereas the person with FTD can probably go for a walk, depending on the person. And we might be limiting them because we're afraid they might wander off, but roaming isn't that common in FTD and wandering isn't that common in FTD. It's usually purposeful exercise that they want to undertake. So you have to kind of think about safety, what can be done to maximize safety. People have done things like their loved one loved to ride a bike. They were avid bike riders, but they weren't safe anymore on a bike. So they got a recumbent bike, which is a bike that has 3 wheels that you sit in. And they were able to do much better with the recumbent bike than they were with the other bike. People have done things like put rings in the home or, so that they know when somebody's leaving or entering, or Google tags or Apple watches, or, looking at technology to see how can you utilize technology to be able to better assess safety, but also maintain independence. Some people do things like if finances become an issue where maybe they're spending inappropriate money and the care partner has to take over finances, maybe they'll give them a prepaid debit card with a certain amount of money on it. So if they want to go get a cup of coffee, they can still go get a cup of coffee earlier on in the disease, but they also can't go buy a car. So these are some examples of things that you can do to kind of change the environment to help the person be more successful, understand that the person isn't going to change. Did that answer your question?
I think so. Thank you.
You're
Next
welcome.
question. We've got a line of them here.
Go ahead.
What can be done when the person with BFFTD becomes out of control, causes immense financial harm, and the doctor says they cannot do anything about it?
Sometimes there's just not a lot that can be done. If they're causing financial harm, unfortunately, what ends up happening is with finances, once the harm is done, there's not a lot you can do to go back and get the money back. Taking over finances as early as you can is promising, and I wish I had a better answer for you, but there isn't a lot that can be done. Obviously, if there's financial misuse, you want to take away access to accounts, checking accounts. You want to make sure that there's notifications being put on things being bought. And in the early signs of BVFTD, because they look so healthy, in quotation marks, they look healthy, they look fine, they run into these issues because they look like they can make a sound financial decision and they cannot make a sound financial decision. So the best that you can do is to get as control as you can of the finances now, and also kind of seek support and additional information and talk to other caregivers in your situation because it is very scary and overwhelming.
Is there ever times when you encourage people to either talk to Adult Protective Services to help get guardianship in that type of scenario? Because they're just not gonna budge, and then that way, you know, the whole family's finances don't go to ruin.
Sometimes going for guardianship is a way to go. Going for guardianship is very expensive. And I kind of give examples because it varies. It depends on the situation. And I would just probably say that AFTD's helpline is here to be able to help and answer your questions. So even if you have really specific questions, we have trained social workers who work our helpline and talk to families all the time about your specific situation. And then they can give resource and guidance based on what you're actually experiencing. It's kind of hard for me to give a broad answer here because I'd have to know more information and details.
Thank you. Next question. My mom displays FTD symptoms, disinhibition, apathy predominantly, but she was diagnosed with Alzheimer's after a brain scan. Should we push for a further test?
It probably depends on the brain scan and where the testing was done. You can always request to have a further workup or get a second opinion. So depending on whether or not they did the test and they said, yes, there's something going on in the brain, and they just gave a broad blanket Alzheimer's. Sometimes doctors will just say it's Alzheimer's. I'd have to know more about the testing that was completed, but you always have the option of going for a further workup. On AFTD's website, they do list FTD experts throughout the country, and in the Virginia area, Johns Hopkins has some wonderful experts in FTD. There's a little bit of a waiting list to get in to be seen, but Johns Hopkins, University of Pennsylvania, they have FTD units that can really do a comprehensive diagnosis, and that you can feel pretty confident that their diagnosis is accurate if you have questions about the diagnosis. I would also say that there's value in getting the accurate diagnosis, but the most important thing for you is to learn how to manage the symptoms that you're dealing with right now. And whether it's Alzheimer's or FTD, the symptoms are still difficult to manage. And so learning how to manage those symptoms is going to be what's probably the most beneficial to you as a care partner. And so if you have to go to the FTD website or the Alzheimer's website or the Lewy body dementia website to gain the insight that you need to be able to best meet your mom's needs, then gather all the information you can to be able to be as well informed as you can be.
Thank you. We did have someone comment about the financial piece. Someone hired an elder care lawyer to help protect their finances. So that was one way someone dealt with that. And then we have another question. Any evidence that FTD causes greater sugar cravings? My spouse exhibits this.
Yes, we hear this often from people. There's been some research, and if you do a little Google search on FTD and sugar cravings, you'll come up with some research that's been out there. But the hypermetabolism causes them to just crave sugary foods and eat an increase in sugary foods. Again, it's what can you do within the environment? So can you minimize the availability of sugary foods? A tray of cookies is probably not a good idea. Sometimes, though, people get agitated when you take away the sugary foods. And so then you really have to look at, is this a battle worth fighting? Or is this a battle that's making all of us more stressed when they already have a neurodegenerative disease? And this might be one of the few things that's bringing them joy. So you really have to find that balance based on your own personal situation and what works for you. Many people with FTD, I've heard say, this is one of the few things that brings me joy. Can I please just have my cookies? And so I think you have to balance it based on your situation and what's happening to the person.
Okay, we have 2 follow-up questions in the room.
So this is a follow-up to something you said earlier, and I'm sorry I didn't ask it then. When someone asked you about timelines and whatnot, and I know it's far from an exact science, but one thing I've always wondered is when doctors, or experts throw out timelines, is that timeline based on onset of symptoms or diagnosis date, that average timeline?
It's typically done on the first symptom onset.
Okay, thank you. That makes a huge difference sometimes.
Yeah.
It does, especially if I just passed through that slide just for time, but the average time to diagnosis for FTD is 3.5 years. And for some people it's longer. So when you're looking at the disease progression, you may already be 3 or 4 years in before you get your diagnosis.
Thank you.
Yeah, I'm going to try to ask my question. Can she hear me?
Yes.
Yeah, hi. Let's see. So I'm mother who's now in a memory care home for 6 months now. He's for the past 3 years, he sleeps all the time, 24/7. It sounds like the apathy. I was glad to hear you talk about that. He has two other typical things I might mention. He was on warfarin for 10 years, a blood thinner. And finally, he's almost deaf. He's very hard of hearing. So I'm wondering if people with this deafness are often diagnosed with or if that sometimes leads to memory disorders.
There's a lot of connection between dementia and hearing loss. What came first, the chicken or the egg? It's hard to tell. I think that you have to imagine that if somebody's losing their ability to hear, they're not hearing well, that's cutting them off from the outside world. So if they're already displaying FTD, or they've been diagnosed with FTD, and then on top of that, they can't hear, that's going to affect their communication and then their level of involvement and their ability to have really quality of life or involvement in other activities. So finding ways to keep them engaged may be a little bit more difficult. Sometimes also you have to recognize that as the disease progresses, very often people sleep more. And this is true within the dementia landscape in general. This isn't just FTD. Within the dementia space, when people are sleeping more and more every day, it's usually signs that your body is just working harder and harder to function. And it's a progression of the disease.
So Esther, the Washington Post here in the DC metro area actually just did a beautiful article on hearing and dementia. Hearing dementia about 2 or 3 weeks ago. So anyone can look that up on the Washington Post. It was very well written.
There's a lot of research on this space too. So I would definitely recommend you do a little Google Scholar search too. I think a well-informed care partner is probably, being well-informed is one of the best tools that you can have to be able to kind of combat and work within the disease space.
All right.
Do you have any other questions, Melissa? Or
I don't have any on here, and I think we got all the ones in the room.
Okay, good. So I just want to talk briefly about the genetics of FTD, and I'm going to skim over this just because somebody asked a question about this earlier. And then I'm going to talk about AFTD and our resources and what we have to offer. And this is just a little bit of a snippet, I think, today of what you can kind of learn about on our website and in other resources. So please just take this as an introduction to learning more about FTD. So is FTD inherited? We talked a little bit about this earlier. About 40% of the time, there's a family history of FTD. But overall, only about 20% of people are being diagnosed with a known genetic variant of FTD. The three most common are C9orf72, GRN, and MAPT. There are currently clinical trials that are happening for those with the GRN mutation of FTD that are really promising, and many people are participating in those types of clinical trials. So AFTD recommends at this point, if you have FTD, to consider genetic counseling if you have a family history of FTD. But that family history, you have to understand, may look a little bit different than they were diagnosed with FTD. There may be a dementia history, there might be a psychiatric history, there might be a history of suicide or other behaviors that in different generations, the FTD was handled differently. And so it presented differently than it is now in this generation and this culture in terms of how we process it. So we have resources on our website about how to do a family history, things to look for and consider, and then ways to talk to a genetic counselor if you're interested. And I know I'm skimming through that really heavy topic really quickly, and I'm so sorry. I wish we had more time today. But I'm going to go through these. I think we talked a lot about them, and I want to talk about AFTD's resources and what we have to offer families. So AFTD is a nonprofit patient advocacy organization, and we were actually created by a caregiver who, with a $1,000 donation, Helen Ann Comstock really decided to help. She knew that FTD needed people caring about it and focusing in on it and supporting caregivers. And so she jumped in, and she was some of the first people staffing our helpline, our first support groups, and really helped us become who we are today. So our mission today is to drive research to a cure, to raise awareness of FTD within the community, to support care partners and persons diagnosed, to educate on FTD to healthcare professionals, care partners, and people living with the disease, and advocate for a better world for those diagnosed with FTD. We have many resources that I want to make sure you're aware of. We have the helpline, like I mentioned before. If you go to our website, or you can email us at info@theafd.org or call us at 866-507-7222. Our helpline is staffed by trained social workers who they do FTD all the time, who can answer your questions, provide support, help you find support. They do everything from, I just got diagnosed, I don't know what to do, to I'm dealing with this behavior. Do you have any suggestions? To how do I manage this? There's a long list of things that they can help you kind of reference and navigate. In addition, I would say go to our website, learn more, log on, peruse through the different pages and see what you can learn about the disease. We also have publications. So we have 2 newsletters that go out. We have Help and Hope that actually goes out every week, and it offers caregiver tips and resources for you to be able to know how to manage the disease, ways to advocate and volunteer. We have Partners in FTD Care, which is a quarterly publication that goes out for healthcare professionals, really focusing on improving access to accurate diagnosis, as well as care and support. And then we have other publications. We have the Doctor Thinks It's FTD Now What, or we call the Green Booklet, that supports people after a new diagnosis. We have Kids and Teens. We have a publication called Walking with Grief, which is really focusing on the grief that's associated with an FTD diagnosis and caring for somebody who you're slowly losing. In addition, AFTD has a grant program. So we offer quality of life grants for persons diagnosed with FTD. Very often these are used for things like recumbent bikes I talked about earlier, home modifications to help the person be able to be more independent. People have used them for craft supplies because they were crafty and it helped them do something they enjoyed. So depending on the person and the area, you can apply for a quality of life grant. In addition, we have a respite grant for care partners. So this is a $500 respite grant. It's modest, but it does provide some support, and it's pretty open. So if you have a child come in or a family member to come sit with your loved one so you can get a break, you could reimburse them through the respite grant. And then in addition, we have a national, regional, and local network of support groups throughout our country that you can access for support. We have some specialized support groups. So we have support groups specifically for people with FTD, ALS, male caregivers. We have support groups for people who are really dealing with the language issues. We have support groups for people living with FTD. So you can go to our website or reach out to the helpline for more information or support. Here is some of the recent Partners in FTD Care that we've done. And then in addition, just want to make you all aware that we are coming upon World FTD Awareness Week. So September 24th through October 1st, it is World FTD Awareness Week, and it's an opportunity for everyone affected by FTD to raise awareness about FTD and show the world that we care. And we want it to be better for those diagnosed and their caregivers.
We have a question for you, Esther. Since the person often doesn't recognize the changes in behavior or communication, what would be a pathway to diagnosis?
I think it's important that you talk to the care provider separately. Very often we recommend, giving a call to the diagnoser or the person you want to talk to and telling them the symptoms and the behaviors that you're seeing. Very often, I've had care partners say, well, since you insist nothing's wrong, let's go to the appointment. They'll prove you right and we'll be done, just to get them there. So a little bit of a workaround when they don't want to get there. But it really depends on the situation and the person. It can be difficult. It's a difficult process when the person refuses to get a diagnosis. Eventually, usually what happens is other symptoms start to present where they start to recognize that something else is happening or something's wrong.
Another question. We've been told the Parkinson's disease cognitive impairment is due to frontal lobe damage. Example, executive function. How can a doctor differentiate between Parkinson's and FTD as the disease diagnosis?
It probably depends on where you were diagnosed in terms of how specific the diagnostic process was. So I would probably have to hear more about what your situation was and what the process was. You can have Parkinson's disease with dementia. You can have FTD with Parkinsonism type symptoms. Once again, you have to go back and recognize that our brains are powerful organs that control every aspect of who we are. And so it is not uncommon with neurocognitive or neurodegenerative diseases for there to be overlap in the symptoms and what they look like. Once again, you really need to understand the symptoms that you're dealing with and find the information and support that you need to manage what's before you.
All right.
So I think I have one more slide that if people would like to be involved with AFTD, we have volunteers who do a lot of different work, whether it's starting support groups like Melissa and the team at Insight does, or whether it's advocating for change, food for thoughts, or different activities. So you can go to our website and learn more ways to be able to volunteer and affect change. And I think that is it. Do we have any more questions?
Yes, but we'll quit.
Well, what is your question? What is your question?
Well, if you want another question, well, yeah, my brother, I'm caregiver for my older brother who is single and has no kids. He's in a home, as I said earlier. He does scare the nurses, nobody there will have anything to do with him. They leave him in his room day and night because he goes like this. I think it's because he doesn't like people talking to him because he's deaf, but he'll go like that. You know, he doesn't hit anybody, but that's his way of communicating. It's aggressive. Yeah.
Yeah, that can be frustrating. I think that's one of those things you talk about in the care plan with them.
A lot
So
of times facilities aren't educated on FTD too. So we have a lot of families who will bring our partners in FTD care and our information to the facility staff to help them better understand the disease and the presentation. So I would just recommend that that's always a good option also.
yes,
If I could, is he verbal?
Yeah.
Okay, does he tell them what he wants?
Because he's deaf, I think he doesn't have the experience anymore of talking very much. So he doesn't say much. Yeah.
So I created a point sheet for one of my clients who has FTD. It has similar aggressions, that way the staff can hold it up. You can pick one of the big boxes and they can go from there and work their way through. I don't know if that's something that might work. The facility could
read.
Yeah, so that might be something the facility could add to the care plan.
yeah, communication boards are great. So, yeah.
Yeah, that sounds like a good suggestion.
Whiteboard.
Yeah.
Whiteboard.
Yeah.
Yeah, whiteboards all over our house.
Well, Esther, we would love to thank you for being here. And before we go, our upcoming events are on the screen. There's one in October that I really want to highlight. We are having the honor of having Scott Rose come to our area here in Northern Virginia on October 12th. And he actually wrote a book about taking care of his wife with FTD. And there will be free books given out. It will also be online for those of you. I know we represent 29 different states Insight reaches out to. So if you're not local, it will be hybrid, so you can see it online. But feel free to get the book We Danced if you want to read it ahead of time. And Scott will be presenting for us in October, which I'm really excited about.
What day is that?
October 12th, I believe, is a Wednesday or a Thursday. Yeah, it's in the evening. Yeah. Yeah, Thursday. Thank you.
Thursday?
Yeah.
Okay.
Looks, we had 2 questions pop up on the Q&A. Oh, they wanted to thank us. This has been very helpful. And then the other one is, can Parkinson's medications affect FTD cognitive impairment like rivastigmine for confusion or nelipizid for delusions?
You need to talk to a specialist about the medications and what's happening, because it really depends on what the presentation of the disease is, what they really think the neuropathology is, and then what the medication is best effective for. I would say a good recommendation is if you're seeing a change and it's not working, it's worth talking to your doctor.
So thank you all for joining us, and we will see you next month. But if you'd like to sign up for any of our other events, go to insightmcc.org/events. And feel free to reach out with any questions after. This is recorded, and we'll probably have it up in about a week online to share it with all of you. Thank you, Esther.
Thank you.
You're welcome. Bye, everyone. Thank you.
Where is she? Do you see?
The Association of California, though.
I thought it was.